Hello and welcome to Level 3 Health and Social Care Stroke Unit. That's Unit 306. We're looking now at Part 4 of Week 2, so that's the second part of Week 2. And we're going to look at risk factors and managing prevalence. So the objectives that we're addressing from your assignment is number 2.1, discuss the risk factors associated with having a CVA and some of the preventative health measures. So overall, the best way to help prevent a stroke is to eat a healthy diet, to exercise regularly, avoid smoking and drinking and too much alcohol. Now, any of you who've done other units with me, you know these generally come up as the answers for most things. So it's a clear guide that, you know, doing those sorts of things can help your general health all over anyway. But focusing back down on stroke specific issues, we'll look first at arteriosclerosis. We talked about that in other parts of the unit. And if you recall, that's the build-up of fat in the arteries that can cause problems and lead to blood clots, which lead to a stroke. So who particularly is at risk for arteriosclerosis? It can actually happen to anybody, although your risk can be increased if you are older, if you smoke, if you have an unhealthy high-fat diet, if you have a lack of exercise, or if you're overweight, if you drink a lot of alcohol, if you have other conditions, including high blood pressure, high cholesterol, or diabetes, if you actually have a family history of it, so if you're genetically predisposed to having arteriosclerosis, there's a good chance that you could have it. And that would be something that if you had a family history, your GP would probably screen for early on or keep an eye on. If you are South Asian, African, or African Caribbean descent, they have quite a high prevalence to arteriosclerosis. So again, if you come from one of those cultures, it will probably, your GP will just sort of check it out and screen you for it every now and then. Some of these things you can't do anything about, obviously. You can't do anything about where you come from. You can't do anything about your family history. But you can do some of the things about managing your diet and managing your exercise and the rest of your lifestyle issues, of course. So looking at atrial fibrillation, if you remember, atrial fibrillation is when the heart beats erratically, not in a normal rhythm. And when it's not in that normal rhythm, this erratic behaviour can throw off blood clots and cause a stroke. So if there is an underlying cause, then treatment for this might solve the problem. Medicines called antiarrhythmics can control atrial fibrillation. They actually just restore a normal rhythm to the heart and they control it. So very often atrial fibrillation will beat, 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 and then beat, 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 beat quite a bit and beat, beat, beat. So it's erratic like that. So they'll try and bring it down to a sort of more of a steady rate. There's a variety of medicines that you can include. Flecainide is one of them. Beta blockers are quite common. So normally people, if someone's arrhythmia was happening quite regularly, they would put people on probably beta blockers or flecainide. Some people have a heart arrhythmia that doesn't cause them a problem, just happens now and then, and very often they might not have any intervention for that. GP might just keep an eye on it and monitor the frequency of it. So controlling the rate of the heart, the aim really is to keep your heart rate down to that average, lower than 90 beats a minute, so 80 to 90, you know, or 70 to 90, but more of it, keeping it as a steady beat rather than this sort of beat, 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 which you see on when you're looking at the blood pressure charts. A beta blocker, as I said, would be quite useful. And sometimes there's another medicine called digoxin, which may be added to help control the heart rate further. And that also sort of um, puts the heart at a steady rate as well. Digoxin is a much older drug. It's a drug that comes from a plant form. It actually comes from the foxglove. And if used when it's not synthesized, it's actually quite poisonous. So don't go around eating foxgloves if you want to control your heart rate, because it will probably give you heart arrhythmias. So it has to be used in a very well managed way. So to avoid a risk of stroke, so as I said, the atrial fibrillation means there's a risk of throwing off blood clots because of this erratic behaviour. If the clots enter the bloodstream, they can cause a stroke. Doctor will keep an eye on you and probably will ask you to go back, be checked. You might have ultrasounds, you might have ECGs very often. They'll have a look at how old you are and you know, all the history issues, whether you've had them before. And they will check if there are any heart valve problems, because sometimes there are problems that can be evolved by fixing with surgery. So it's really to find out what is the cause of AF, really. As I said, some people just are born with it, and some people it might have come from some sort of accident, which they might be able to fix. Constant high blood pressure, untreated, could also bring around atrial fibrillation. So one of the drugs that we've mentioned here is warfarin is anticoagulant. I mentioned a few other anticoagulants before. So an anticoagulant is a drug that thins the blood to stop it from clotting. So that's what anticoagulant means, it stops clotting. Okay. There are many others, but warfarin is probably one of the most commonly heard ones. So if you're working in a care home, you might come across quite a few people who are taking warfarin. There's some things to think about when people are taking warfarin. It's fairly effective. It's good to people who have high to moderate risk, but it does need to be monitored. So for this reason, people have to go back and have regular blood tests, because warfarin thins the blood. So they have to make sure that the blood isn't going too thin. So when people take it regularly, they will go back every so many months and have a swift blood test, which is usually done quite quickly, and they'll often can get the results there then and there while they're waiting, to see that the blood hasn't thinned too much. And if it is a bit too thin, they might reduce the warfarin or even take a break from it. If it's okay, if it's still quite sticky, they might bring up the warfarin, or they'll just keep it as it is. So it's really quite important. There are some increased risks of bleeding. So there's a lot of management to think about with warfarin. You have to make sure, if you're looking after people, if they have cuts or bangs on their feet, just monitor them to make sure they do stop bleeding, because unfortunately one of the side effects of warfarin, keeping the blood thin so it doesn't clot. So normally when you cut your finger, you sit there for a while, the blood will start to clot. With warfarin, it doesn't always clot, so we have to keep an eye on that. Make sure people don't, you know, suffer from a wound that could keep bleeding. Also, more importantly, is looking out for internal injury. So if someone on warfarin maybe has a fall or bangs themselves, there's no obvious signs, but you do need to put some monitoring in place just in case they have any internal injuries, and that will show up by pain and discomfort in certain areas, heat, sensitive to the touch, and maybe some underskin bruising, which you would need to really keep an eye on just in case, because it could have internal bleeding, and unfortunately with warfarin the bleeding might not stop. So just, you know, keep an eye on all your service users with warfarin. Just keep an eye on them in case they, you know, if they injure themselves, bump or bruise themselves, keep that little bit of extra eye is quite important. And note any changes as well when you're working with them. When you take warfarin, you have to be careful about drinking a lot of alcohol. Avoid binge drinking because it could cause, because alcohol irritates the lining of the stomach. With warfarin, it's very easy to bleed, so the lining of the stomach could get irritated, and that could cause a bleed, and the bleed could bleed quite substantially because you're not clotting again. And strangely enough, cranberry juice and grapefruit juice interacts with the warfarin, and it's not recommended. So it can cause the warfarin to stop working or work overtime and cause a problem. But you're not supposed to drink cranberry juice and grapefruit juice. I don't know the science behind that. I'm sure you could look it up if you wanted to, though. There are some other anticoagulants for people who don't get on with warfarin. That's rivaroxaban, dabigatran, apixaban as well. But they all work in the same way, and you still want to keep an idea on people's clotting and check their bloods because, you know, there could be some problems with long clotting. Okay, apart from warfarin, you can have surgical intervention. We can have something called catheter ablation. If you have a look at the graphic that I've given you there, it's a procedure that very carefully destroys the diseased area of your heart. It's something people might opt for if medication hasn't really worked. They put some very thin wires known as catheters. They thread them down through the aortic valves into your heart. There they record the electrical activity. And they will find by moving them around where the source of the problem is, where the abnormality that's causing your arrhythmia. So it will be this high energy electrical activity, or it will be uneven compared to the rest of it. And once they've found that, they put another little wire on it. If you can see, there's 2 or 3 wires there, having a look. And through that wire, there's very high frequency radio waves are sent down, and they generate a heat that actually destroys that bit of tissue. So there'll be a little part of your heart where the tissue has been destroyed, but actually that's better off for the heart than a bit where this bit is malfunctioning. So it sounds a bit worrying, but you know, they're just tiny areas really, but it's enough to cause malfunction. So once they've zapped it, once you recover a little bit from that, then the rest of the heart will just carry on as normal. It can be a quick procedure if they get to it quick, or it can take ages if they have to spend a lot of time looking for the affected area. So normally you'd be unconscious during this procedure, but I have known it to be done in day cases nowadays. People make a fairly quick recovery. It's not that debilitating, and within a day or so, you're back to normal and you're out and about really. But they do say you can't drive for a couple of days, and you shouldn't do any heavy lifting. You shouldn't put any pressure on the heart because it's still healing from the sort of burning, the heat source having destroyed that thing. So you have to give it a couple of weeks to heal, so you don't put a lot of pressure on it. Otherwise, though, people usually get about the house quite easily, so you don't need that sort of help. So that's one type of surgical intervention. Another surgical intervention you may have heard more of, or you may know of people who have got one, or you may be working with people, is a pacemaker. It's a battery operated device, and they implant it in the chest. It's usually just here, just below the collarbone. And it's usually, it stops the heart beating too slowly, regularly. But sometimes if you've got AF, where your heart beats too fast or beats erratically, the pacemaker can actually work on that as well. So it's got a sort of double use really. So it can be used for quite a few different issues where your heart is not working at the proper rate, too slow or too fast. And as you can see, it's put in, have a look in the graphic. You see the pacemaker lays just here. The wires run down through the aorta, and then they go into the heart, and they're parked in the different ventricles, and they keep the rhythm going nicely. So it avoids people having a stroke or a heart attack as well, really. And pacemakers now are sort of fairly routine. Every now and then you go into hospital to have it checked. Usually just for the afternoon. It's not a big deal really nowadays. A few things to think about if you've got a pacemaker. You can't go into any areas where there's magnets, big magnets. So you need to, most important thing is if you're flying and you can't go through the metal screens that where you walk through to check if you've got any weapons or anything like that, in security. So you have to let people know you've got a pacemaker, because otherwise going through that screen, it's certainly going to set the screen off. It's also going to could have a negative effect on your pacemaker, which is even worse. So they would normally take you round and do a hand check for that. So please remember that if you've got a pacemaker, don't walk through the metal screens. It could kill you, really. And the other thing is, people have to know if you have an MRI scan or a CAT scan, because they've got huge magnets involved in there, and that will cause some serious damage. So you have to stay away from things like that. If in doubt and you think it could be damaging, you just sort of take somebody to a side and say, I've got a pacemaker, can this cause me a problem? It's usually the electrical metal detectors things you'll come across. So if you go into a shop with them, or a hotel, because I've seen them in hotels as well, you just have to sort of call security and say, look, I can't go through that, I've got a pacemaker. To be honest, if they want you to go through it, say, sorry, mate, I'm not coming in here, because it could cause you a lot of damage. Okay, now one of the more common issues for leading to strokes is high blood pressure. We know that. And we do know that those simple lifestyle changes that we've talked about more than once can help reduce high blood pressure. Although sometimes some people need to take medication as well. So when is treatment recommended? It depends on the regularity of your high blood pressure and how big a risk they think you are. So it really depends on the numbers that you're producing. It's easy to take blood tests, but just a blood pressure machine alone, regular blood pressure reports will soon tell you where you are. If your blood pressure is consistently above 140/90 and your risk of other problems is low, so you don't have any attendant risks, you'll be advised to try and deal with the lifestyle changes first, and then they'll see how you get on. And if for some reason you can't make those lifestyle changes, they might consider using medication. Now, if your blood is consistently above 140/90 and you have other risks like family disposition, you might have additional diabetes or some of the things we've already been talking about, or AF, then you'll be immediately offered medicine to lower your blood pressure, because it's important for the GP to get that down. If your blood pressure is consistently high, 160/100, you'll be immediately offered to lower your blood pressure, but then they'll try and get you to do the lifestyle changes. Well, in fact, all the way through, they try to get you to do the lifestyle changes, because very often doing those, even if they don't take you off the medicine, it can certainly reduce the amount of medicine you have to have over time. So it's often a combination of the two. Some of the medicines for high blood pressure, there's two types really. ACE inhibitors, they're called ACE, antigenesin converting enzyme, generally known as ACE, and that reduces the blood pressure by relaxing your blood vessels, so they're not quite so tight and they're not pushing it so hard through. And then there's another one called ARBs, angiotensin 2 receptor blockers, and they work in a very similar way. And they're often recommended if you don't tolerate the ACE inhibitors. Some of the common examples of the ACE inhibitors are enalapril, isirapril, penidopril. So often they've got a pril on the end, you've got a good chance of knowing that they're probably high blood pressure medicine, really. But, you know, don't be positive on that. It's something you could check. They do have some side effects. You can often have a persistent dry cough with them, and some people can get headaches or dizziness and a rash. So if someone's been given new blood pressure medicines and you're working with them, just look out for things like that. If you're aged, if you're 55 or under, you'll probably be given the ACE inhibitors or the ARBs. If you're aged 55 or older, or you're of African or Caribbean origin, they'll often give you a calcium channel blocker. And this just works in a slightly different way. It relates to your history, but has the same effect eventually. It just works slightly different. It works on calcium. You may need to take this blood pressure medicine for the rest of your life, but if you really do well with the lifestyle, you can actually bring it right down. And sometimes the doctors will stop treatment if they think people have really developed, or they'll stop it for a while, monitor it, because the aim is not to keep you on sort of long-term medication as much as possible. Another issue is high cholesterol, we've mentioned before, and you might need medicine to lower your cholesterol. Cholesterol is usually checked for a blood test, quite easy blood test. You can get the results pretty immediately with a little dipstick. So normally, if you're identified to have high cholesterol, they'll give you a chance to sort of change your diet, lifestyle, the usual things for a few weeks, see how you're getting on. If, however, you have any of the other contraindications, you have another high risk of heart attack or stroke, they might start your medication. But generally, they do like to get you to try to do it with diet and lifestyle. They will give you statins. It's a common medicine for high cholesterol, and statins actually reduce the amount of cholesterol your body makes. You take the tablets once a day, and you will probably take them forever. Although I have known people to come off statins if they've made some real big changes in their lifestyle, usually in the way they eat. And the doctor will monitor that. They will check you, and they will check your cholesterol on a regular basis. So you'll go for a general MOT, they'll do blood pressure, cholesterol check, those sorts of things. If people are at high risk of stroke, though, they may keep people on the statins. So thinking about those people, if you remember when we talked about different types of strokes, one of the ones we talked about was TIAs, transient ischemic attacks. Remember we talked about them as mini strokes, which were sort of precursors to a big stroke, although when clots would form, but they would break up and move on. So you would have what was known as a sort of incident or a mini stroke, really. And those who have TIA may need to take medication because they want to reduce the risk of having a full stroke or reduce the amount of TIA that they have. And one of the things that they will give you is aspirin. Now, I know we all take aspirin for all sorts of things, but the aspirin that they give to you is a very, very tiny amount. So usually we would take 100, 200 milligrams of aspirin when we've got headaches. These are special aspirin tablets, so you don't really mix them up. And they're like 25 milligrams up to 75 milligrams. So they're much, much smaller doses, and they've got a special coating around them. So they're a bit different, and they don't really work well. So I wouldn't use them as your painkillers because they're not usually good enough. They're a different type of aspirin. I mean, it is aspirin, but they're specially developed for people having TIAs. And you'll normally be given the aspirin straight after a suspected TIA, and it's an antiplatelet medicine. And platelets are the blood cells that help blood to clot. So reduce the amount of platelets that you're producing keeps the blood a little bit thinner. It's not quite as extreme as warfarin, but it stops those platelets sticking together and forming clots. So they're not as sticky, is probably the best way of putting it. There are other medications that you can have that's a bit more serious. And the main side effect of antiplatelet medicines can be a bit of indigestion, can upset your tummy a bit, and increased risk of bleeding. Not quite as much as the warfarin, but because you're on aspirin and the platelets aren't sticking, you do still have to be a bit more careful. If you have a cut, if you cut, you bleed for longer, but just again to keep an eye on it to make sure you have stopped bleeding. And you be aware that you'll find that people who are on aspirin, they get a lot of superficial bruises very easily. You only just sort of bang his hand like that and you'll get a bruise coming up. And again, they just keep an eye on it and it should usually go down. If someone has an awful lot of TIAs, they might go on to the more serious anticoagulants such as the warfarin. So we talked about the lifestyle changes, and we know those because we've discussed them in other units, but I need to go over them and reinforce them again because they're always important and they're always part of the answer to the question, really. Lifestyle diets. Unhealthy diet can increase your chances of having a stroke. It will lead to an increase in your blood pressure and it will lead to an increase in your cholesterol level. So you need a low-fat, high-fiber diet. And that includes plenty of fresh fruit and vegetables and whole grains. And you need to ensure your diet is balanced. So this is no time for a cabbage only diet or a boiled egg only diet. So you don't eat too much of one single food. But most importantly is keep your salt levels down. So don't add too much salt to your food. And try not to eat too much processed food like processed meats, packaged meals and those sorts of things because they often have very high salt content as well as sugar content and all sorts of things that are generally unpleasant. You need to limit your amount of salt a day to no more than 6 grams. That's 0.2 of an ounce. 6 grams of salt is about a teaspoonful. Think of your teaspoon, and you shouldn't have more than that in a day. So just think about what you do when you're cooking. And again, if you do happen to have a meal in a packet, please check the salt content on the side. You might be surprised how much is already in there. You also need to drink less caffeine, which is in coffee, tea and cola. Particularly if you have high blood pressure, you need to reduce your caffeine level. Coffee is the main culprit, but things like Coke we know has got caffeine. You can get caffeine-free versions. I personally don't like it, but so I have to just try and think how much I've had really. Exercise, I guess we sort of are not surprised to see that here. Combining a healthy diet and regular exercise is a good way. It maintains your weight and keeps your body fit as well. So that can help lower your cholesterol and it can help lower your blood pressure as well. For most people, at least 150 minutes every week is recommended. It's 2 hours, 30 minutes, moderate intensity, cycling or walking, swimming maybe, going to the gym. Well, it doesn't really matter what you do as long as you do it. If you're recovering from stroke, you really need to talk to a rehab team and they will work out an exercise plan with you. So don't just suddenly decide to run a marathon because you might not be able to. It might not be possible for the first week or months after a stroke, but after this, as your rehab progresses, you should be able to do it. But again, the rehab team really work it out with you. So just be guided by them. Smoking, I guess most of us really know about smoking. It's one of the particular causes of arteriosclerosis. There's a lovely gruesome picture here of you can see the inside of a blood vessel that's full of the fat, the residue from cigarettes, and how it gums it up. So therefore, that one's gummed up half a blood vessel there. It's not very nice, really. Looks quite disgusting. So smoking significantly increases your risk of having a stroke, and it narrows your arteries, and it can also make them quite hard. So you get the fatty plaque, but also the arterial walls get quite thick, and that means that they narrow again, but they can get quite hard, so they lose their flexibility as well. So stopping smoking is a great way to reduce your risk of having a stroke. Sorry. Not smoking will also improve your general health, give you more energy, enable you to be able to exercise better, and it will avoid lung cancer and other major heart diseases. So what's not to do? Cut down on alcohol. Excessive alcohol consumption can also lead to high blood pressure, and it can trigger atrial fibrillation, particularly if you're prone to it, which you probably already know about. Alcoholic drinks are also high in calories, so they add towards weight gain. And heavy drinking multiplies the risk of a stroke about more than 3 times. So you're more than 3 times as likely to have a stroke if you drink a lot. If you choose to drink alcohol and have fully recovered from your stroke, you should aim not to exceed the recommended limits. Men and women are advised to not regularly drink more than 14 units a week. A unit is half a pint if you drink pints of beer, or I think a glass of wine. So just remember that. So make sure downsize the size of the wine glasses you are, and eat something before you go out as well, because that's sort of quite good. Spread your drinking over 3 days or more if you drink those 14 units. If you haven't really recovered from a stroke, you'll find that people who are recovering stroke can be quite sensitive to alcohol. So even just the recommended limit might be a little bit too much for them. It's the same as anyone who's not 100% healthy here. But there's a few tips there to help you as well. Little things to make it a bit easier. But there's lots of things you can do to find out more about cutting down on alcohol. So finally, the last one, obesity. Being overweight or obese definitely raises your chance of a stroke, especially if you carry the extra body fat around your waist. So if you're an apple-shaped body, if you have a look at my graphic here, someone who's got lots of belly fat, and otherwise are fairly straight, we call that an apple body. Otherwise, the other people have a lot of extra weight around their hips and thighs. We call that a pear-shaped body. That is a lower risk of stroke. It's the apple-shaped bodies. The ones who are just round with sticky out arms and legs. They're the high risk people for stroke. So to lower your risk of stroke, your body mass index, BMI, should be between 18.5 and 24.9. There's lots of BMI machines you can get checked on. Sometimes we have them in supermarkets and chemists and pharmacies and things like that. Or they probably have one at your doctor's surgery. You can go and have a check. A BMI between 25 and 29.9 is definitely considered overweight, and anything 30 and above is considered obese. So you know where you are, really. But most people nowadays know their own body weight and their own body frame, and they know when they're obese. So you can either measure it yourself, but just by weight. But if you're doing it by BMI, which most of the nurses in clinics tend to go by BMI rather than sort of pounds and ounces weight, really. They tend to go by BMI. So the most important thing is to go back to that diet at the beginning and try to do that. Keep your weight down. If you keep your weight down, chances of not having a stroke again will be much lower. Okay. So that's all I have for you, really. That's a little bit about managing prevalence. Okay, I'll see you in the next session. Thank you and goodbye.